Okay, welcome to 2021 AP Valve Structural Heart Meeting. And so we also prepared a very interesting case. This is one of the toughest complex case. Before starting this case, I'm going to introduce our team. My name is D.W. Park in Asa Medical Center. And the right is he is Ho-Jin Kim. He's a cardiac surgeon. He has a proctoring in TAVR procedure. And the second is assistant is the junior staff is Do-Yun Kang. Professor Kang, and could you explain the patient background? What is the key point of this patient? What we should be concerned? And could you explain?
Yes, the patient is 86-year-old female and who referred for the treatment of severe aortic stenosis. She underwent evaluation for the effort dyspnea, and her echo showed the severe degenerative aortic stenosis with moderate AR. And she also has the history of the paroxysmal atrial fibrillation. Next. And because of the very old age, 86, and her STS mortality score is 6.4%. Next. And echo showed normal ejection fraction of 56% and very severe degenerative aortic stenosis with the transaortic velocity max 5.4 meter per second with the peak and mean pressure gradient of the 117 and 78 millimeter mercury. And next, ECG showed the sinus rhythm. Next, and chest X-ray showed the cardiomegaly with the tortuous aortic silhouette. Next. And this is the CT evaluation of the patient. This is the EKG gated multi-detector CT. And the aortic annulus showed a long diameter of 9.8 millimeter and 25 millimeter with the annulus area 388 square millimeter. Next. And this is another section of the sinus of Valsalva and ST junction. Sinus Valsalva to annulus area ratio is more than 2. That means that the area of the sinus Valsalva is large enough. And ST junction to annulus area ratio is 1.9. That means that ST junction is large enough and there is a very low risk of the ST junction damage during the TAVR procedure. Next. And this is LVOT view. There is a very spotty calcification, but the LVOT area is large enough and relatively clear. Next. And this is the calcium view, and the measured calcium amount of 850 Hounsfield unit is about 450 cubic millimeter. That means the intermediate amount of the calcification in the valve. Next. This is a 3D view. Next. And the coronary height is high enough, more than 10 millimeter. Left coronary artery and right coronary artery coronary height from the annulus is 11 and about 17 millimeter. Next. And this is the problem that you can see that the iliofemoral arteries are very, very tortuous. And next, this is the whole aortic view that shows the very tortuous anatomy. But in the can you please show the previous slide? And you can see the iliofemoral artery is the amount of the calcification is low, and there's no very severe calcification. So I believe that with using the very stiff wires, then the tortuosity can be overcome. Next, and next. Next. Yeah. This is the size chart for Sapiens 3 valve. That means that with the 23 millimeter valve, we can achieve the area oversize of 6%. And with the 26 millimeter valve, we can achieve the area oversize of 34%. And this is how we select the valve size.
Okay.
Yeah.
So, looking at aortic valve complexity, there was not severe, and just we decided to 23 1 cc overfill.
Yeah.
There was 15% oversizing. And the highlight portion of this procedure, and could you show the angiogram showing how much difficult So, and looking at this is the angiogram. This is a patient, this is 86-year-old female, and looking at the, we're gonna usually use the sapphire wire and the stiff wire, but although looking at this cine angiogram, you definitely feel how much difficult the tortuous aorta. You know, we recently completed 1,000 case TAVR case. Professor Kim, did you see before this complex case?
No, I don't think we have seen such a very tortuous aorta, but
this is, I think, most complex tortuous aorta. This is definitely not easy case. So, looking at over here and the left femoral vein, we put the temporary pacemaker, left femoral artery, we put the pigtail catheter, and the right we do puncture, and then here what is the catheter name?
This is the glide.
Glide. So I'm gonna. This is shows the Lundquist wire. There was sometimes used for the peripheral artery intervention, and the Lundquist make a band at top of the over here. So I'm gonna put the Lundquist and then try to put the issues. So my planning, if insertion Lundquist aorta still there are significant bending, and we should consider another Lundquist from the left femoral artery. There was two Lundquist wire.
Yeah.
Okay, could you show us the low part?
Here.
Okay, over here, this is Lundquist wire. Is the glide? Okay, slowly over here. Okay, curve was gently elongated over here. Okay, tip was not yet. Wow, over here. Okay, over here. Okay, we can see there was some, okay, over here. And then pull back the glide, and looking at the curve and the much straighten the aorta wire. There was how much strengthen you can compare the left femoral artery, the pigtail catheter. There was Lundquist wire. Okay, over here, and then on the pullback glide. Okay, could you pull back? And then I'm gonna remove the sheath and then try to insert of the issues.
Yeah, issues is ready, and this is the dilator.
Dilator first.
Yeah.
Okay. Okay, slowly, okay. The dry gauze. Okay. Okay, over here. Okay, I insert. This is a dilator, and slowly upper part. Could you show us the upper part? Okay, got it. Over here, you can see the dilated well. Okay, got it. And then, okay. Could you remove? Okay, got it.
Okay.
Yes, and then I try to insert issues. 423. This is 14 French issues. Okay, got it. Over here, wait. Could you show us the low part? Okay. We can insert. Okay, smoothly. Okay, over here. Tip over here. Okay, we can put the insert and smoothly is at the end of the aorta. This is nearly thoracic aorta, and then the suture. Pushing. Okay, got it. The suture. Okay, Professor Kim, could you go there? So, and very tortuous abdominal aorta and thoracic aorta. This is, I think, one of the extreme case, and you should definitely consider very strong wire. On the kist is one of representative wire. So I saw the TAVR cases performed in Columbia University, and the similar case. Sometimes you cannot pass the valve well, you cannot pass the issues well, and you should consider two on the kist. One is from the left figure tail, and one is the right, and that would be some more the make a straightening of the valve, the curve. Okay, got it. And then over here, this is the
AL1.
AL1.
catheter.
Okay, we should
Zoom in.
zoom in. Okay, 더 와야지. Okay. Okay, got it. Wow, the taperon first.
앞에 있습니다.
Okay. I tried to do elbow wiring. Could you show us the baseline aortogram? Wow, this is the overriding horizontal aortic curve. Okay. 네, 센터로 하고. Okay, got it. Okay. It's a very severe AS. Wow. Okay, taperon wire.
Yeah, this is the taperon wire, and this is another ring torque straight wire.
This is ring torque, so much strong wire. Okay, it's okay, got it. Safe. Wow. Okay, this is insert. Wow. Okay, got it. And then
팟캐스트로.
run the cast.
Yeah.
이거 프레셔를 줘야 되니까 일단은 okay, run the cast. Okay, make a band over here. Primer. Where is primer? Okay, primer and the make a band over here. This is some hardest part over here, and the make a sufficient band over here. Okay, got it. Okay. Wow. Okay, wow. Oh. Wow. And then remove and pigtail. 자, 보면서 되죠. Could you pull back over here? And then the pigtail caster. Okay. This is one of the toughest case for overriding heart, very horizontal heart, as well as very severe tortuous abdominal and thoracic aorta. And this is pigtail. Okay, we should require repositioning of the elbow wire.
Yeah.
Okay, got it. Got it. Okay, over here. Okay. And then initially measure pressure. That was our routine. Oh. Okay, flush. Trimmer, could you show us, okay, hand up trimmer. Okay, looking at the
As the red line is the LV pressure, and green line is the aortic pressure.
Okay, you can easily find out how much is significant aortic valve the pressure gradient,
Yeah.
and then I'm gonna put the round caster again in the LV and the repositioning of the LV wire. Could you put the okay, 잠깐만. Okay, got it. Here. Put again the round kist. Wow. Okay, gently insert on the kist. Okay. 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 Okay, do you? Okay, slowly pull back. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. Okay, and then the valve.
Yes, valve is ready with the 23
23.
millimeter Sapien 3 with
okay.
1 cc overfill to achieve 15% oversizing for annulus.
Okay, after the finishing this case, I'm gonna show such a tortuous angle. Sometimes some the difficult or complicated thing happen during the pushing the valve. Okay, the insert one, slowly push, and slowly push, slowly push. Okay, I can do that. 이거 해주고 많이 잘 잡고. Okay, great. Over here. Okay, could you pull back over here? Okay, let's keep the wire. That is the most important part. Okay, got it. Slowly. Okay, slowly. And okay, just stop it. So, and this part over here, and that was happening. Looking at the pusher tip, there was such like angle. There was if alignment not match, there was some kinking of the valve.
Yeah.
Okay. Slowly. Wow. Okay, more. Little more. Okay, little more. Okay, and then the finish up. There was a very common things in the very tortuous. Okay, over here. Okay, the rock, and then okay. Push. Okay, more. Okay, got it. Yeah. So there was that phenomenon we can explain the later. Okay, insert, make a band, much band, and then insert and keep the wire. That is the most important part.
Yes, I'm keeping the wire.
Okay, got it. And then make a pull band over here, and then make a pull band. Okay, got it. And then the coplanar view.
맞습니다. 줌하겠습니다.
Over here is coplanar view. Is make a pull band over here. Okay, got it. Is keep the. Wow. Okay, slightly test.
테스트.
Okay, got it. Okay, I'm gonna handle this over. The axis is not good. Okay, test.
테스트.
Okay, pressure is okay. And then slowly pull back. Okay, test.
테스트.
Okay, got it. Okay, dye is sufficient.
예, 충분합니다.
Test one more. Okay, got it. Okay, everybody is ready?
Yeah, ready?
Okay, slowly, gently. Okay, pacing on. Contrast. Okay, inflate. 1, 2, 3, 4, 5. Deflate. Okay, pacing off. Okay, got it. And then slowly pull back the pacing off. 1, 2, 3. 1, 2, 3. Pull back the band. Okay, got it. 1, 2, 3. 1 to 3, 1 to 3, 1 to 3, 1 to 3, 1 to 3. Okay, 1 to 3. Okay, tension release slowly. Okay. Okay, got it. Could you check it up the transthoracic echo immediately? Okay, during the MAC procedure, we're gonna usually the left to check it up. Okay, got it. I think the position is okay. Is looking at the transesophageal echo, and there was no the pericardial effusion. That was the first thing we should make sure. And then there's no significant PVR. Okay, show the axis view.
Blood pressure is stable with systolic blood pressure 112.
Okay, there was no significant PVR. Okay, we're gonna check it up, the angio.
Angio ready.
Okay. This is the coplanar view. Okay, angio. Okay, push out. Okay, so I think that was a very long-cast wire, strong wire that was caused some wire effect, and then remove, and then the diastolic pressure is 81. That means it's diastolic, the PVL would be okay, and then remove, and then change it to the catheter. Okay, 1 to 3, 1 to 3, 1 to 3, 1 to 3, 1 to 3. 1 to 3, 1 to 3. Okay, got it. And then pigtail catheter. Okay, got it. Okay, insert. This is pigtail catheter. Okay, over here. Okay, inserted well. Okay. And then the measure. Okay, we're gonna check the LV and Elta diagram. Okay, Do-Young-Gang, could you
Yes,
explain?
again,
Is it after flushing?
Yeah, red line is the aortic pressure, LV pressure, and green line is the aortic pressure. And you can see that the
great.
pressure gradient between aorta and LV is relatively almost zero.
Almost the zero.
Yeah, and the degree of the aortic regurgitation is very low. Because that the green line, there's the very small degree of the pressure drop
PVL is
during
looking
the
at
diastole.
air index
Yeah.
more than 50.
Yeah.
That was a very excellent. And then we're gonna remove over here.
pigtail.
와이어 될까요?
보였구나. wire.
스티바이어 되겠습니다.
네, steel wire. And then we're gonna check it up the final angio, and then discuss during the procedure there was something, and we're gonna explain what we should be cautious about such a very tortuous aortic case. Over here, okay. Okay, got it. Okay. Then the wire over here. This is contrast. Okay, got it.
에어 리무브 하겠습니다.
Air remove. Okay, test. Okay, got it.
레디.
Okay, we're gonna check it up. Okay, enjoy. Full shot. Oh, excellent. There is no air PVL. And okay, great. And the RA view. Okay, enjoy. Okay. Oh, great. And so I think the result is excellent. And you, the audience, during the procedure already recognized at the time of the pull back the balloon, try to the process, the mount, try to pull back the balloon. and that during that times the pusher should go up the valve. So and such like a very tortuous case, the alignment is not good. So usually if you're gonna pull back the balloon and the pusher tip over here, the valve here, and you're gonna the moving up the pusher, and there was a easily go up.
Yeah.
But such like a case, since alignment is not so good, there was a pusher tip, there was some the artificial crack. So
Yeah.
in the valve frame can pinch of the frame. That means some going up the process. There was some problem. So we prepared a very similar case.
Yeah.
And could you explain the Doyungang and
Yes.
our 2 days ago same case, a very torturous case. The same things is happens. Could you?
This is
Okay.
another case of the very tortuous LT anatomy, and you can see during the pulling back the balloon, the valve, the
Alignment
distal
is
side
not so
of the
good. Yeah.
valve is pinched in the ischias.
Okay, and the looking at over here, and there was the difficult part over here, valve over there, and the pull back the balloon. That were the things that sometimes happen, but at the time the interventional cardiologists have the anxious about we cannot make sure the exact positioning of the valve on top of the balloon. So at this moment, during this case, the same things was happening. So I'm gonna emphasize the first step. We put the very strong wire that makes sure so much the one line alignment that avoid such happenings. That was our the technical tip of this complex procedure. And if I'm gonna summarize this case, very severe 2 and 3 curve the angle at this moment, and we should consider the diverse vascular complication. And the first step, this is a very same things about the PCI and guiding. The stable guiding catheter is the first step. That is the same in the TAVR procedure. The stable guide wire support and the Elta wire support is the most important part, and such like a very tortuous Elta and the round kissed wire is very essential and very helpful to avoid such like several technical the obstacle and limitation. And we use just one round cast wire. Sometimes we require the 2 round cast wire, and the result was excellent. During the procedure, there is a lot of technical challenging, but the result is very excellent, very successful. The story and okay. And Professor Kim, any comment for such
I
case?
didn't see this happen before when I do the procedures, but you just resolved. So what should we do when that happens? You pull back the pusher a little bit.
Right. Yeah, there is usually, and if these things was happened and a little bit the tension release, and then try to make alignment more straightforward. There was a much upward part move and the slow part, and we try to avoid the most angled part that can easily happen. So we try to move a system is much proximal or much distal, and try to avoid most curved part. Yes.
So we have to make this as straight as possible.
Yeah, definitely.
Realign the pusher.
Yeah,
and
alignment,
then
make
start over again. Okay.
Definitely.
Yeah.
That is the most important part. Okay, Do-Young-Gang, any comment for this case?
This is a very interesting case with showing the importance of the procedure preparation before the procedure.
Okay.
We evaluate the CT and evaluate the tortuosity of the Elta, and we thought we prepared every method to use to overcome the obstacle and could be successful eventually.
So, usually looking at the routine, the TAVR patients, their age is more than 80, and there are very diverse spectrum anatomy in the aortic valve anatomy and the ascending aorta anatomy and the aortic curve anatomy, and not the same case at all. And we should consider lots of things about this is one of extreme case, a very severe tortuous aorta. We should consider strong wire and the valve in valve case and low coronary height, bicuspid valve, and very diverse, complex situation. I believe, I think, and if you have many cumulative experience, definitely we can do even in the complex type of the patients. Okay, so I hope the audience and the panel and discussant and really enjoyed and learned a lot of things from this case. And this is another extreme our type of case, and I hope that you learned a lot of things from this case. And we're gonna finish and this interesting and VALVE 2021 live case demonstration. Thank you. Thank you.
Thank you.
Yeah.
Good morning and good afternoon and good evening, our friend. And I'm very happy to join this live case demonstration. So today we will prepare another different type of bicuspid valve. We will treat the different modalities. So I'm going to introduce our team. So this team, the joint international fellow and the light is Dr. Ko from Japan. And the assistant is Dr. Kosadi from Saudi Arabia. Okay, Dr. Go, can you present the patient background?
Yes, thank you. The case is 83 years old male who referred to AMC for treatment of severe aortic stenosis. She had dyspnea on exertion several months ago, and her echocardiac finding shows a bicuspid aortic valve with severe degenerative AS and moderate AR. His symptom is dyspnea on exertion, NYHA function 2, and next. His medical history is diabetes and hypertension, and also have atrial fibrillation. SDS score is 2.1, and his body size is very average in Asian population. BMI is 23.5, and next. EKG showing the atrial fibrillation, and next. X-ray showing a little bit of congestion, and next. As you can see, ejection fraction is well preserved, 51%, and the mean pressure gradient is elevated 56 millimeter mercury, and the peak velocity is 4.5 meter per sec. And also this patient got moderate AR, and next. This is a CT measurement of the annulus. As you can see, this patient have atrial fibrillation, so slightly have a motion artifact. So the annulus short diameter, long diameter is 25.3 millimeter and 31.8 millimeter, and the annulus area is 628 millimeter square, and the annulus perimeter is 19.1 millimeter. And next. So what we focus on this slide is a ratio between sinus and SOV and ST junction. In SOV, the ratio is 1.78 relative to annulus, and in ST junction, the ratio is 1.20 relative to annulus, meaning that this patient have a very average size of sinus valsalva and relatively smaller size of ST junction. And in the middle of the picture, as you can see, we can see some calcify commissioner between left coronal cusp and the right coronary cusp. And next.
This is a type 1 bicuspid
Yes,
valve.
this is a type 1 bicuspid. And the LVOT doesn't have any calcium. And next. This is the total amount of calcification. Total amount of calcium is 780 cubic millimeter. And next. The distribution is not extending to the LVOT. And next. Coronary height is more than 12. And next. Peripheral is quite large enough for transfemoral approach. And next. So today we have decided to do the Evolut R, and according to our sizing chart, our usual target oversizing is 120% to 130% oversizing. But this patient have a bicuspid valve, so today we have chosen Evolut R 34. And next. So this is a co-planar view, and Professor Diderot, please.
Okay, so if I'm gonna summarize this patient, 84-year-old male, and presented of dyspnea and multiple risk factor, atrial fibrillation, diabetic, and hypertension, also, and anatomically very interesting type 1, the bicuspid valve calcium amount is huge, 780. Yes. So I think there are some discussion point and which valve type would be nice and the the good preferred option is a balloon expandable versus and self-expandable also, and looking at the calcium amount to 780 and 90, and if you're gonna select a specific type of the valve and the pre-dilation do or don't do, and I would like to hear some expert panel opinion for this case.
Yeah, so I think hi, Dr. Park, this is the Viniva part. So I would actually, we had a great case on the other side. So Dr. Vijay Kumar, this is not that calcified valve. Would you do a BAV in this patient?
Yes,
See, by rule for a bicuspid valve, even if there is calcium, you have to do a pre-dilatation, because if you don't do pre-dilatation, then at the end, post-dilatation, you will end up requiring, and the gradients would still be remaining. It's just that if there is a moderate calcium, you can slightly undersize the balloon. Otherwise, actually all bicuspid valves, especially this type 1 valve, I would go for a good pre-dilatation without doubt, and not fearing about stroke happening.
Okay.
Just that we have to be a bit careful that you don't break or rupture the calcium and there's a severe AR happening on the table immediately. That caution one has to take. Otherwise, one size under would be very good.
How about Jian Wang? And you have a very nice experience of treating bicuspid valve. In this case, usually you do pre-dilation or not doing the pre-dilation.
I think we can't hear you.
Yeah.
I think Dr. Wang is not available in this time.
Oh,
Okay.
So I think I think he is. I can barely see him. Dr. S.C. Chang, in Taiwan, what you do in bicuspid, like especially this is a size 34 Evolut R. It's the biggest size you're going to use. This has got good radial strength. The calcification is not huge. Is there a real value? Some people argue if you pre-dilate, you may loosen it more and not anchor it very well for self-expanding.
Yes, in my daily practice, I will use the pre-dilatation also, because it is a bicuspid, and although just only have a moderate calcification, but I think pre-dilatation will have a very good passage of the Evolut R, especially in this case, we have to use Evolut R. So I will do the pre-dilatation for this case.
So
And by the way, in Taiwan, we also have about 10%, in my experience, about 10% patient will have the bicuspid valve.
Yes.
So anyone in the panel would use a 29S3 in this situation? It's a type 1.
I think it would be totally fine to use a 29S3 here as well.
I agree.
I think this one, we can use either. I think
Either of
Yes,
either of the two. Okay.
So, and if you select the 29, the SafeN 3 valve, and the sizing is nearly 0% oversizing.
yes, 103%.
Yeah. And so, we're gonna do more dilation. It's SafeN 3 29 for 2 or 3 cc. So, and looking at the hemodynamics, continuously monitoring simultaneously, and you can see how much severe AS, also how much severe AR, and the end-diastolic pressure in the nearly narrowed. So we already decided, and the pre-dilation, and then Evolut R, and the 34. And the reason why pre-dilation, previously we have some bad experience, calcium amount of 800, 900, after insertion of Evolut system doesn't expand. So at the time, we're gonna do post-dilation with balloon, but there is some pop-up, there is some risk of the severe calcified region, and so reason why we're gonna do a pre-dilation, such like a very severe calcified region.
What size balloon are you going to use?
Yes, 23, and we are usually 2 sizes down. Yeah, this is a Safari small. Okay. And then
this is a man, right? This is not a woman.
Yeah, it's not woman.
The slides were confusing, but I was going to say this is one of the largest ANOs I've ever seen.
Okay, this is
This is a big
Safari wire. It's small인가? big인가?
This is a small.
Small. Okay. 1, 2, 3. 1, 2, 3.
Dr. Parker, can you hear me?
Okay, we can hear you. Okay.
Okay, sorry, I just
하나,
I
둘,
don't
셋.
know why you cannot hear me.
Okay.
So I prefer, my prefer is pre-dilatation is my prefer, especially for the BAV patients. You know that even some patients, they are BAV patient without a very severe calcification, but the leaflet may be very thick. So we need to do the dilatation.
오케이.
Especially the
네,
super
낼게요. 딱 잡았지?
네, 잡았습니다.
자, 1, 2, 3. 3. This is
I think
23.
everybody agrees that pre-dilatation is important, and Asan Medical has a good algorithm, I think, 2 sizes down balloon, which is probably pretty standard as everybody else said. This is a 83-year-old. I think this is a relatively, I think, less debate about TAVR or not, although it's type 1.
Okay.
Yeah, I think this is a much more, this is a pretty easy choice here.
Okay.
The balloon is also expanding right in the center, unlike what we saw.
1, 2, 3. 1, 2, 3.
So again, I think very good point there.
This is 23. 자, 1, 2, 3. 1, 2, 3.
So how big is the balloon size?
This is 23.
23.
Okay.
23. Okay.
Okay.
So
And then
CD,
we're gonna insert and the Evolut R and
And I assume
34.
in DW, you still don't have the Evolut Pro or the Pro Plus in Korea yet, right?
Yeah, just this is Evolut R system, and the Evolut Pro is also available.
Yes.
Yeah, but it's less than 29. Yeah, right.
Yes.
But now you're not, so you do not have the Pro Plus 34 yet.
Yeah, right.
so how big
Wire
size
strip.
of the device are you going to select?
This is 34 Evolut R system. Okay.
I think if it was a slightly larger size, you could go for Pro. And again, the vessel size decides which system you're going to use.
천천히.
I mean, the vessel was big. I mean, so in the
I
US,
think-
I would use a
I
Pro.
think
here.
so. Maybe the size is a little bit larger.
잡았지?
네, 잡았습니다.
Okay, this is port. Is 3 o'clock.
So what would be the valve option in China for such patients?
Okay.
I-
커플라는 비율을 먼저 하고.
So in China, most we use venous.
Okay, 주맥제.
And what size venous you will be using in this
For
experiment?
me, this
And
case, I
marker
made
with great
the
curvature is good.
venous 26,
Okay, here and then cursive overlap view.
similar to the Corval 26, I think.
You know,
But not
So the venous valve
is,
size is same as the Evolut R
26
size.
is maybe a good choice, but 29 is big enough. 32,
됐어?
maybe a little bit
Okay, got
larger.
it.
Do you think that 29 would be large enough
Yes.
because of?
This-
I think
Super
29 is big enough, absolutely big enough.
This is a cursive overlap view, and usually cursive overlap view is too much hazard to operator. Is RAU, the deep RAU, deep overlap view. Okay, got it.
Operator friendly.
자, 여기서 테스트.
Nowadays,
usually and the low margin of the pigtail, I'm gonna release over here. This is some guidance of the cursive overlap view. Okay, 천천히. 자, 120 pacing. Okay, release. Okay, release. Okay, 천천히. Okay,
So how
천천히.
many people
Okay,
in the
test.
panel use cusp overlap in
Yeah,
bicuspid
release.
patients?
Okay, release.
James?
I don't know, I mean, the,
Release. 혈압 떨어지면
sometimes it's hard to find 3 cusps
320. Okay. Release.
for these. I mean, I think the point is to get the,
Okay,
you know,
release.
align it with the bottom of the non-coronary cusp and keep the parallax out of the valve.
Release.
I mean, those are the 2 critical points. I don't really care so much where the other
Okay,
cusps are.
release. Test.
혈압이
This looks like a very good
release.
position to me.
혈압이
Okay, got
떨어집니다.
it. Okay. Blood pressure is going down. 좀 더 해도 된다. Okay, we're gonna wait. This is cursive overlap view. Okay, got it. 자, 혈압 올라가지. Okay, and during the release and blood pressure is down, and then it's going up.
60으로
자,
바꿔.
Okay.
You want to reduce your pacing? Yeah.
Okay, got it. 자, 천천히 됐지. 자, is blood pressure is going over 100. 자, 테스트. So I
Okay.
think, I think this is very excellent.
Yeah.
So, okay, Dr. Go, could you check it up, the intracardiac echo?
Yes.
This is, we apply the, the intracardiac echo. Okay, got it. Can you see the intracardiac echo finding?
Yes.
Okay.
This is the long axis view, and we don't see any PVR
Any
right now.
PVR?
카라 한번 빼죠.
칼 한번 빼줘보세요.
빼고.
Okay. Blood pressure is excellent, and the diastolic is 90. That means the usual result is perfect.
카라 on.
Okay, good.
I think we don't see any
PVR.
So
okay, great.
I'm gonna move on to the short axis.
Yes.
Cut out.
Intracardiac echo is very useful, and is perpendicular in the right atrium. Is good to see longitudinal view if you're gonna approach the aortic complex part, and we can see the aortic the biplane view. Okay, over here. Okay, good.
So are you doing many of your cases with intracardiac echo?
Yes, sometimes, especially for live case demonstration.
No, it's very unusual to see.
Yeah.
Because it might be useful if it's a challenging case as well.
Okay, good.
I think that's only the mild PVL, so should be optimal.
Very good.
Okay, great. So it's time to release. Okay.
코플라너 뷰 가겠습니다.
코플라너 view.
Do you ever swing over to LAO before you release to see, just to make sure it's going to catch on the left?
Yes, so I think and the view here we check it up, the cursive overlap view and the lateral view, the 3 cursive view. Okay, 여기서 한번 체크를 몇 군데 해보고 릴리스를 하자.
찍어볼까요?
테스트 한번. 테스트 살짝. 테스트. 오케이, 한번 찍어볼게.
Yeah, it looks good.
Hi, Dr. Park. So would you introduce how do you achieve
릴리스 할게.
a good alignment?
천천히. Okay. At this moment, and the tension release is very important. Okay. Okay, got it.
I'm gonna
pull back the wire and push the sheath. Okay, release.
Yes.
Release. 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 Tension release.
Yeah.
Release. Okay, release. Pull release. Pull release. Not yet. Not yet. Release. Okay, got it. So here, at this moment, sometimes nose cone going up the valve and gently pull back over here, over here, over here. Okay, and then we're gonna measure the AP를 놓고 이제, and then measure the simultaneously pressure. Okay.
붙이겠습니다.
뒤에 붙이고.
결합하겠습니다.
Okay.
So do you at this point also check the symmetrical deployment in another view?
Yes, we will check it up.
Okay.
Okay, 됐지? 자, 같이 뺀다. 자, 하나, 둘, 셋. 1, 2, 3. 1, 2, 3. 1, 2, 3. 잠깐만. 자, 1, 2, 3. 1, 2, 3. 됐다. 됐어. Okay. 지금 and sometimes use intracardiac echo is useful, sometimes not user friendly.
Yes. The problem is sometimes interfere with temporal pacing, so we have to be careful.
Okay. So, and for treatment of bicuspid valve, and is Dr. Yoon published in JAMA article using STS TVT registry, mainly the balloon expandable valve showing a very nice result in the mortality issue as well as hemodynamic issue. So I think Evolut is also very good, another option for treatment of the bicuspid valve. Okay, pressure.
Absolutely. I mean, I think 4 years ago, a lot of bicuspids were not done at all. And then initially it started with Evolut R, I would say, and then slowly now more Sapiens are being used. So I think in United States, David, you think that the split is 50-50 among operators?
I think probably it's close to 50-50. I mean, we know in the US that there's a predominance of balloon expandable valves used across all patients. I think in the bicuspids is an area where I think people, a lot of people like to use the self-expanding. So she's pretty bradycardic. I wonder if she has some heart block in AFib here.
Okay. 자, 여기서 이게 프레셔죠?
Jungan, what is the practice in Cedars
이거
at
다
present?
이거지?
Mainly balloon expandable for bicuspids
Okay,
of what
right.
type?
This type of the anatomy is favorable, so we prefer the Edwards balloon expandable. And if there's a combination of everything, cholesterol Lafayette, LVOT calcification, and difficult sizing, so then we choose self-expanding.
Okay, we're gonna show the simultaneous pressure monitoring. This patient is atrial fibrillation. Looking at there is no pressure gradient, AR index more than 35 and 40 and there is you can easily find this. There is a very nice hemodynamic result. And the diastolic pressure is very nice. AR index more than 35 and 40. So, and we're gonna check it up the final view, and this is a pull back the pigtail over here.
You also cured the atrial fibrillation. There is a question about bradycardia. The patient's heart rate is very low.
Yeah.
So, what would be your approach in?
여기는 여러 개에서 찍어보자. 아래 이게 이제 코플라나뷰죠?
코플라는 아레오 코다에 갈까요? 먼저 아레오 코다에 가겠습니다.
아레오 코다.
잠깐만요.
Okay.
많이 갑니다.
Okay. This is possible view over here. I hate cursive overlap view. Okay.
I also hate it when the valve embolizes.
Okay. And you're ready? Okay. Push shot. Okay, good. Okay, we're gonna move to another view. 자, lateral view랑
처음 그 트라이커스 뷰로
트라이커스 뷰로 한번 가보자. 오케이.
좀 맞추겠습니다.
오케이.
레디?
자, 테스트 살짝
테스트.
오케이. 엔조 레디? 자, 준비됐다. 자, 풀샷. 오케이, great. 오케이. 그 다음에 저쪽 뷰로 해서 잘 펴졌는지 한번 볼까? 네. LA, lastly, we're gonna check it up the LA view. Over here. Okay, we expanded well. Okay, push out. Good. So, and hemodynamics is great. Also, the final Elta angiogram, there is no PVR. Also, you can see this is the short axis of intracardiac echo. We find that there is absolutely no AR, and the result is excellent. So I think this case is one of a very nice example case to treat with the Evolus system, the self-expandable system. Also, there are many interesting points of valve selection, sizing, and predilation. Also, useful tool for intracardiac echo. So, any comment or question to this case?
So, one of the question asked is the patient's heart rate is very low. So, what is your policy or strategy in terms of leaving the temporary pacing wire?
Yeah, so usually, and we do and keep in coronary ICU is coronary care unit is 1 day for keep the temporary pacemaker, and tomorrow we will check it up. Usually, it's most of the case and the recover of heart rate and remove the temporary. Nowadays, our overall rate of temporary the permanent pacemaker after insertion of the Evolus system is 7%, 8%. For Sapien series is less than 5%.
Yes, 4.4.
So, yeah. So, and still we after insertion of the TAVR valve, we keep the 3 and 4 days. I know there are some benchmark program in the Sapien series, and early discharge was recommended to some experienced center. We still keep the classic and conventional. After insertion of the TAVR valve, we usually keep the 3 and 4 days.
So anyone from panel wants to add, like we have a policy of at this point swapping. We generally use pacemaker wire from the neck for that reason. And I know the centers in England, they're using pacemaker wire from the brachial vein as well now, so that patient can be ambulated. So that's something to consider as well.
Yeah, we would put the pacer in from the neck at this point just because it's going to stay in for a bit of time. I think that, I mean, to me, one of the really interesting things in this case, you can see it both on the intracardiac echo as well as on the fluoroscopy, is how asymmetrically expanded the annulus is. It really is very oval here. In this dimension, it's quite short, but if you go to the LAO, it's much larger, and you can really see that eccentricity in the ice as well. I think one of the nice things about the core valve platform is, since the valve is superannular, the valve itself can be much more circular because it's up above this area where it's constrained. So it's a nice feature, and it's probably why the hemodynamics are so good in this case. So it's really a great example.
And I think there's no indication of post-dilatation here because there's no regurgitation.
Yeah, definitely. Right. These patients, no indication of the post-dilation.
Yes.
So if you're gonna do post-dilation, there is some risk of pop-up.
So at what point?
No gradients, no.
Yeah.
Okay, go ahead. You just post-dilate for getting a valve symmetric is the question.
No, that's not. I don't think that's an indication right now. Not yet. What are you doing now for your post-procedure anticoagulation in these patients routinely? Are you using single or dual antiplatelet now?
This patient got the atrial fibrillation.
Yeah, this patient's
this one, okay.
Yeah, we keep, the David Cohen, the specialty for antithrombotic therapy at the TAVR, and we just, this patient, atrial fibrillation, prescribed no ARC. So nowadays, still without not indicated for oral anticoagulation, we keep the DEP therapy and sometimes do aspirin alone.
Yes.
Yeah.
Mm-hmm.
Can we poll the panel on that? I would be curious to hear what everybody is doing for a patient who has no indication for oral anticoagulation. What is the standard?
Our routine is single antiplatelet now.
And which single?
We go aspirin alone.
Aspirin alone. Okay. And Dr. Kumar?
Yes, here also as a single antiplatelet aspirin is preferred for these cases. And in the presence of atrial fibrillation, of course, we just put them on NOAC.
Just a NOAC, no antiplatelet at all.
No antiplatelets.
This is the most controversial topic in my view, and I'm not just saying as a surgeon, but I just think that the use of antiplatelet in TAVR is extrapolated from the stent world, which is completely wrong. And we are all being carried away for like 15 years on that now. I think with the incidence of halt, which we are observing in all the devices, I think the time has come to investigate whether there's a role for 3 months of proper anticoagulation, and then probably nothing after that, and then see the incidence of halt. So we are about to start a prospective study in my center where patients will be given, we are treating low-risk patients now, so they can have, same as SAVR, they can have 3 months of anticoagulation, and then they will get a CT at 6 months and 1 year to see what is the incidence of halt.
But this is a single one.
Leaflets is completely voodoo.
Well, it's all voodoo. I mean, well, we know, we know a few things. I guess at least based on the studies we've seen, we know that dual antiplatelet therapy is riskier than single antiplatelet therapy, and didn't seem to improve outcomes. And so far, the two studies that have tested DOACs, whether low dose or high dose, have all shown either higher mortality or trends towards higher mortality with the DOAC. So it's I mean, I think this is an area where we still need good research, not empiricism.
Minneapolis Heart Center for years now, before I came, it's my 1 year actually yesterday, but the policy has been single antiplatelet, and then the patient gets a CT scan in the follow-up, and then only if there is halt, a signal of anything, leaflet thickening, they get anticoagulation, and then 3 months later, another CT. So by that, we have reduced the, so to speak, apprehension around the whole therapy. But I think the next step is, as I said, reverse. We give 3-month anticoagulation in low-risk patients with TAVR, and then see what really happens. Maybe that will give us some answers.
That would in the future help in avoiding unnecessary CT scans also, if the guideline gets established.
Yeah, because I think for SAVR, the guideline is 3 months anticoagulation. So now I think it's time to apply it for TAVR. It's a no-brainer to me, I mean.
And especially with the low-risk patients going ahead, there is no harm in giving anticoagulation. No harm at all.
And that's the reason we are about to start our prospective study here. And hopefully we will share the results in at least next 8 months or 9 months.
We'll look forward to it. I think DW, I think we are just about out of time. Is there any final comments you want to make?
Okay, got it. And thank you for joining in our very educational live cast demonstration. It's all of my friends. I'm looking forward to see you next year at Valve meeting in person. We would like to join the dinner with some alcohol beverage and something like that. And I hope that everyone be healthy and be healthy always. I hope to see you next year. Thank you.
Thank you so much. Thank you very much.
And a great case. Congratulations to the team.